Welcome to Healthcare from the Hill. I'm your host, Dr. Amit Lahav, and in this show we discuss medical-related issues and topics. We also interview the individual from the physician all the way to the patient. Today we have a very exciting show. It's spring, sports coming around the corner. We have t-ball, baseball, softball, and with me today we have our esteemed colleague, personal friend of mine, Dr. Schachter, specializes in sports medicine and arthroscopy. And we're going to discuss the shoulder, especially rotator cuff, all the way from the young individual to the older individual, and those that are young at heart, as well as instability, things like dislocations, especially for pitchers. So stay tuned. It's Healthcare from the Hill. I'm Dr. Amit Lahav, and we'll be right back to talk about the shoulder. Welcome to Healthcare from the Hill. I'm Dr. Amit Lahav, and today we're going to talk about the shoulder, specifically rotator cuff and instability. You know, baseball is right around the corner. And when you pitch, there's a lot of motion on that shoulder. So we'd like to talk about what happens to the shoulder, especially things like instability, dislocation, especially in the younger individual. It's a lot of force in the shoulder when you're in that position for pitching. But also rotator cuff injuries, especially as you get older. Things can happen for the shoulder where the rotator cuff are those muscles that help mobilize the shoulder. They can tear, and there are different types of tears that can occur. I'd like to go maybe to a little presentation, if we can go to our slide presentation, on the shoulder, just to give you a little background on rotator cuff and perhaps some instability. So we'll talk about the shoulder, and let's begin with the rotator cuff. If you look really at the body has the skeleton and obviously the muscles that cover that skeleton to give that skeleton functionality, to move the joints. No matter how big you are, it's still the basics. You have the skeleton and then the muscles overlying the skeletons that give that function. If you look at an x-ray for the shoulder, on the left side of the screen is the ball, or the humeral head. On the right side is the socket. And you can see in the shoulder, it's a fairly shallow socket and a larger ball. The rotator cuff is a group of muscles, and it's actually 4 muscles that give that functionality to the shoulder. There is one muscle in the front called the subscapularis, the one on top called the supraspinatus, and there are 2 in the back, the infraspinatus and the teres minor. And they all work together to give that mobility to the shoulder. But what happens when you have a rotator cuff tear? As illustrated in this cartoon here, when there is a cuff tear, the ball can actually slide higher than your socket, especially for larger type of tears, where the deltoid, the muscle that you feel on top of the shoulder, gives that pull up. And that actually changes the biomechanics of the shoulder and can also cause discomfort and pain. This is just an x-ray that shows the ball again on the left, the socket's on the right, but you can see that the ball is shifted much higher than the socket. It's shifted up because this is a massive or very large rotator cuff tear. So the function of this shoulder is going to be compromised. MRIs are very helpful to assess rotator cuff injuries because MRIs help you see the soft tissues, where x-rays really allow you to see more of the bone. And here, where it's marked S on the upper left side of the screen, that's where the supraspinatus, or the one that's most commonly torn out of the rotator cuff, generally inserts into the humeral head. But it's actually shifted all the way to the right, where the black area is, and that's why the humeral head, or the black, is shifted up, showing that there is a tear in the rotator cuff, and that white on top is actually fluid, showing that there is no structure that's there, which is the rotator cuff. So this is just another schematic showing what happens. And there's the rotator cuff tear as shown there. And as it gets bigger, where the head is just underneath, then there's nothing supporting the head on top, and the head can shift up, touching your acromion, which is all the way in the top side of the screen. The muscle all the way in the front, which also shows a little bit injury, is a subscapularis. That's a muscle that helps you internally rotate your shoulder. We generally fix these rotator cuff tears arthroscopically, except for some exceptions, but mostly arthroscopically, which means that there are no large incisions around the shoulders. It's generally done all sort of an inside with a camera with smaller incisions about the shoulder. And we'll speak to Dr. Schachter specifically about this, since that is his specialty. So what's shown here is just a needle showing the bare bone, which is a humeral head, and the rotator cuff, which is the white, almost blanket right next to it, which should be attached down to the bone, but here it's not. There's actually a hole that's there, and it's starting to pull off the bone. So we have to essentially get that back to the bone and reattach it. Schematic showing what happens here in a supraspinatus, and there's different ways to fix it, but we essentially have to suture or tie it down, back down to the bone, and allow it to scar down and heal, providing, again, that functionality to the shoulder. Let's briefly talk about instability in the labrum. The labrum is actually a soft tissue around the shoulder. Again, talking about pitching or throwing, there's a lot of mechanics that go in the shoulder, and there's different phases of throwing which affect the shoulder differently, all the way from holding the ball to releasing the ball. If you look at the shoulder, there's the capsule, the labrum, and the tendons. On the left side, the glenoid or the socket is actually that small pear-shaped structure in the middle. It's a very shallow socket. So if you don't have the soft tissues around it and the labrum and the tendons, which give you dynamic stability to the shoulder, the ball will just slip right out. Unlike the hip, where the hip has a lot of bony congruity, which holds the ball in the socket, the shoulder is completely different, which is why also the shoulder has such great range of motion, because it's not limited just by the bony anatomy, but the stability is inherent really to the soft tissue structures. So the labrum is that soft tissue around the bone or the glenoid or the socket of the shoulder, which deepens the socket with soft tissue, again giving some more stability. But that labrum can essentially tear. And the biceps, which is the biceps tendon, essentially inserted onto the superior glenoid, also provides some stability, which can essentially come off if something happens. So I'd like to maybe just come back to it in a little bit, but maybe start talking about really rotator cuff injuries. And I'd like to introduce my esteemed colleague and a personal friend, Dr. Aaron Schachter. He specializes in sports medicine and arthroscopy, and he has special interest really in the shoulder. He's worked with the New York Jets and the Long Island Islanders, has a long history of sports, including himself in his younger years, although still very young and young at heart, and very active. So sports really is the main thing that he does. Shoulder is his interest, and he really does up to state-of-the-art techniques regarding shoulder surgery. So thank you very much for being here with us, Dr.
Thanks for having me.
So I like to say that I've been in the OR with you, and you know the utmost, most recent techniques in shoulder surgery. You never cut corners. When you do something, you do it from A to Z, and it's sort of like the gold standard of repair when you're in the operating room, no matter what it is, from a small tear in the rotator cuff to a massive, large tear in the rotator cuff. So just for history, maybe you can go over sort of your background and your interest in shoulder.
Sure. So my background is I did a sports subspecialty training, as you mentioned, and because of the topic in general, sports, there are a lot of shoulder injuries involved. And you made a great point before. The hip really is a ball in a socket, but as you noticed before, the shoulder is really a golf ball on a tee. And with the loss of bony constraint that you don't have in the shoulder, it produces a tremendous amount of force on the soft tissues around the shoulder, namely structures such as the rotator cuff and the labrum. And because those soft tissues do see so much strain, soft tissue injuries about the shoulder are much more common than they are at other quote-unquote ball and socket joints.
So really for the shoulder, more for throwers, like, quarterback,
Sure.
pitchers,
Especially.
as opposed to, a catcher, for instance.
Sure. Sure. So in the end, we all love our teams and we love our pitchers, but the things that they do, the shoulder maybe wasn't necessarily made to do. To be in that late cocking phase does produce a tremendous amount of strain on the shoulder, and it gives rise to injuries of the rotator cuff, which are, in the end, a minority of rotator cuff injuries. Most rotator cuff injuries are degenerative, and it's not that nothing happened traumatically, it's just this is a repetitive micro-trauma over time and time and time.
So let's actually talk about the rotator cuff.
Sure.
And in the rotator cuff, I want to differentiate sort of a younger individual rotator cuff pathology or injury compared to an older individual with rotator cuff tear or pathology.
Sure. So the younger individual, depending on how young the individual is, at a young age, such as teens and 20s, rotator cuff tears are actually extremely uncommon, probably with the exception of the overhand athlete, and particularly a pitcher. As people get older, the rotator cuff inherently degenerates. It is absolutely a part of aging. So the older we get, kind of the weaker it gets, and it starts on the inside out. And certainly there are two groups of rotator cuff problems. There's the traumatic problem, i.e. the shoulder didn't hurt, sustained a fall, dislocation, particularly over age 40, and they can have an acute loss of function and pain, as opposed to the older individual who will develop over time a degenerative rotator cuff tear. And certainly we treat those two groups of people differently.
So generally when you have a younger individual that, let's say, comes to your office, say I have a rotator cuff tear and they're 22-year-old, off the bat, unless they were involved in a major trauma with a penetrating injury to the shoulder that
Right.
cut that rotator cuff, it generally doesn't particularly exist in that mode.
They may have symptoms from a rotator cuff problem, but it would be extremely unusual to truly have a rotator cuff tear.
So more like a tendonitis, or sometimes what we call a posterior superior impingement.
Sure.
There's impingement of the rotator cuff, but no particular tear. Things that are more like partial tears.
Sure. Or even just an irritation, and a lot of times that is a pain that results from a mechanical dysfunction. It can lead to pain there. It is unusual to cause a tear there, but that type of mechanical dysfunction typically is very well treated conservatively with activity modifications, rest, and physical therapy.
So most of the time, really, the conservative management for those type of tears is sort of the mainstay of treatment.
Absolutely, absolutely.
Now let's go sort of to the older individual. Now in the older individual, again, there's actually a watershed area of the rotator cuff, which means the blood supply to the insertion of the rotator cuff on the shoulder is not that great, which is why we see particular tears that occur as we get older.
Absolutely. We could illustrate it on the model if we could pan into this.
So this
is a shoulder. If we could close in on this. Great. So this is a shoulder. We've taken off the deltoid muscles, which is what you can see when you look at your shoulder. Here's the collarbone, and this is obviously the front of the shoulder. And this is the rotator cuff, tendon in the front, the tendons on the top. It's called the rotator cuff because one of the functions, obviously, is to rotate the shoulder. It also initiates motion in the shoulder, and it is a cuff of tissue. So these tendons, although they're from 4 distinct muscles, when they insert, it's very, very difficult when you're looking at it to tell one difference from one and the other. Most of these tendon injuries occur within a centimeter or two of their insertion on the bone, right around here. This is the watershed area you're talking about. Like all tendons, they connect muscle to bone to provide for the mechanics. And so this is the area that we're talking about. Most tendon tears do not occur where there's a big piece of tendon on one side and a big piece on the other side, but rather an avulsion type failure at or around the insertion onto the bone.
So we're able to actually take that tendon and fix it back to the bone, not
Right.
essentially sew tendon to tendon.
Right, and that's the goal. And there's a bunch of different ways to do it. You could, at every shoulder meeting, there are going to be people to debate which way is one or which way is the other. anchors, construction of anchors, configuration of anchors, tunnels. But when it comes down to it, we're all trying to get the tendon onto the bone. And in the end, whether you use an anchor or tunnels or how many anchors you use, it's all about a material like this. This is a high tensile, non-absorbable suture.
So maybe if we can actually zoom on that. It's a very strong type of sort of stitch or suture.
Yeah, actually when you tie with this a lot, it will cut you before it breaks. You could probably hang from the ceiling from this little suture right here.
And that's actually a suture that we use to fix the rotator cuff back to the bone.
Right, you put the suture up through the tendon and you sew it back down onto the bone.
And once the tendon heals, actually you don't need that suture anymore because now it anchors back to the bone itself.
Correct, you don't need it anymore. It will always be in there though, because the rate limiting step with rotator cuff problems is that it takes a really long time to heal. So there's concern if you use an absorbable material that it may lose its strength before the tendon heals. So with the goal always being the tendon to heal, we'll accept having suture in there even though it's not needed, as opposed to suture that becomes too weak too soon.
So essentially that stays in there forever.
Forever.
Now let's talk about even some of the older individuals. A lot of individuals can get rotator cuff tears and they may not even know about it, which means that they compensate pretty well for it. Some become symptomatic, usually after a trauma. Something happens that this sort of crossed that line that was asymptomatic before and then it becomes symptomatic.
Correct.
Why don't we talk a little bit about that? How do you know if you have a rotator cuff tear? Let's say you're 70 years old and you've been doing fine.
So if you have a rotator cuff tear and you're 70 years old, you may not even know it, because there is a part of the population that will develop rotator cuff tears over time that are asymptomatic. Once people become symptomatic, the symptoms are typical. They have shoulder pain, particularly with using their arms at or above shoulder level. The pain is typically on the side of the arm, the way we're wired on the inside. We would call it subdeltoid. You feel like it's under the deltoid muscle, or you may even feel it in your arm. It's typically an aching pain and particularly painful at night.
Will they notice any particular weakness?
Sometimes it kind of depends on the pattern of tear, whether or not it's traumatic. Typically patients with degenerative tears won't notice any acute weakness. That's because this tear, which develops over time, happens slowly enough that people can compensate, the other muscles around the shoulder can compensate. With a traumatic rotator cuff tear, such as after a fall, there's can be a profound weakness to the point that somebody can't even lift their arm up in the air, not necessarily because it hurts, but because with that acute loss of function, they don't have the time to develop that compensation, and mechanically their deltoid muscle has no counterforce.
So if you do have, let's say, an older individual comes to your office and they do have some limited shoulder function, and you do your exam, which we can touch on, and also for rotator cuff, but you do the exam, there is some weakness. How do you, let's say, work up that patient, decide if you want to go something conservative versus surgical, for instance?
Well, I think the key is, especially with the initial evaluation, the key is all in what the patient says to you. In the absence of a traumatic event, we hear the symptoms, we know it's probably rotator cuff. We don't always get so concerned about, is it a tear, is it a large tear, partial tear, because in the absence of trauma, many people can do well conservatively, a majority of people. So in the absence of trauma, we will almost always start conservatively unless they've already failed a conservative management. When somebody has an acute loss of shoulder function after an injury, that's a little more pressing. So that is something that instead of doing some physical therapy, rest, maybe an injection, that's the individual that we're going to work up a little more aggressively with imaging such as an MRI like you showed before.
Because that patient really has a big step down from having a functional shoulder to a non-functional shoulder acutely.
Correct, and the natural history of that is poor, we know that, so that's why we like to treat it a little more aggressively.
So for that individual, a lot of times the surgery may be more of the primary choice.
Correct. We know the natural history of an untreated traumatic rotator cuff tear is poor. Once that tendon tears, especially a large one, and it retracts away from where it wants to be, like you showed in that MRI, very retracted tear, there is no potential for that tendon to get back. The tendon is suspended between the muscle and the bone. When it's not attached to the bone, muscle being a contractile tissue will pull it away.
So, the large rotator cuffs that can occur, again, can be initially asymptomatic, but then become symptomatic. Let's say you do take a patient to the operating room. They failed conservative management. they're ready to have something done. They can't really raise up anymore. They can't reach up.
Sure.
They're trying to even pick up a gallon of milk and they can't lift it. You take them to the operating room. They have, let's say, a moderate to large tear.
Sure.
What would they expect after surgery? Let's say, assuming you do it, again, with your credentials and your specialty and your expertise, you do it arthroscopic, you get it down, you repaired it well, and we can touch about exactly how you repair it,
Sure.
but what should they expect afterwards? They come out of surgery.
So the thing about rotator cuff recovery is that it's long. And that's because we have to wait for the biology to happen, that tendon healing onto bone. And right now, today, we're not exactly sure how to accelerate that. So you have to go slowly. And it's usually a period of immobilization in a sling from anywhere to 4 to 6 weeks. Kind of depends on the tear, how balanced it is, how retracted it was. And we begin physical therapy very slowly because going faster, more aggressively, doesn't necessarily promote a better outcome. Actually, it could interfere with outcome. So I tell everybody that we have to go slow, and it's a long recovery, and it's not like it's 4 or 5 months and then you turn on a switch and it's all better, but it's very long and drawn out because we need to be very careful with these.
So initially you have to remind the patient that you can't just go and lift up your shoulder right away.
No, because you're just working on the construct. There's not been any healing yet, and we really don't want to test. We don't want to test that repair too soon.
So all you're doing is you're pulling really through your stitches,
Just
through your
pulling
sutures.
through the stitches.
And the stitch is actually going to be stronger than the tendon itself.
Absolutely. When they don't heal, it's never. I don't want to say never, but overwhelmingly the failure is at the tissue and suture interface. So you might go back in one and you'll see your knots and they'll be sitting there and they'll be tied and going through the bone, no longer attached to the tendon, which is usually somewhere off in the right field.
So initially you got to protect the patient with a sort of a sling or shoulder brace, which holds the shoulder in a certain position for a period of time until things kind of start to heal. Then initially you start some motion, which is called passive motion. You have somebody else move your shoulder because you don't want to pull through that repair, but you want to try to lessen some of the stiffness that occurs in the shoulder. Then over time becomes active assisted, and then finally active when the patient on their own start moving it. But you can expect a little bit of stiffness that can occur, and you have to work through that. But the main thing is to try to get it to heal first.
Exactly. That's going to be the goal. So I always tell people if we're going to err on one side or the other, we'd rather have a shoulder that is healed and is a little stiff as opposed to a shoulder that if you can use your other arm, it'll go everywhere, but it doesn't go anywhere by itself.
So again, you want to restore that functionality. We're going to take a short break, and we'll be right back again to talk about the shoulder with Dr. Aaron Schachter. Stay tuned for Healthcare from the Hill.
This can't be love, 'cause I feel so well. No sobs, no sorrows, no sighs. This can't be love. I get no dizzy spells. My head is not in the skies. My heart does not stand still. Just hear it beat. This is too sweet to be love. This can't be love because I feel so well. Still I love to look in your
Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and with us today we have Dr. Aaron Schachter, specializing in sports medicine and arthroscopy, and we're talking about the shoulder. We are just completely talking about rotator cuff injuries, and I want to sort of jump a little bit forward now to instability and labrum, and then we'll kind of revisit them both afterwards. If we can really go back to the slideshow, please. So this will be instability and the labrum. And as I mentioned before, there's different phases of throwing which places a lot of stress on the shoulder. The shoulder, again, has a very shallow socket, and the soft tissue, the capsule labrum and tendons, really give it that stability to the shoulder. Here, showing the labrum again, the glenoid is the socket. The labrum, which is a soft tissue around, gives you that more stability or deepens the socket. And you have your biceps tendon, which attaches on top. And this is an arthroscopic picture. The socket is on the bottom, the biceps is coming up the top. And this is sort of a hook showing that the biceps, which anchors on top of the shoulder socket or the glenoid, is starting to lift off. This also provides some inherent stability to the shoulder. Here is showing the front part of the shoulder, and the ball is to the bottom, the socket's to the right, and the labrum, which is the soft tissue on the front part of the socket, has been pulled off, making the socket again more shallow. So there's more issue of having stability of the shoulder. The ball can actually slide off the socket. So what do? We got to take that labrum and that soft tissue and attach it back to the socket with an anchor and sutures. And this is essentially the suture that Dr. Schachter have shown us, where we take that soft tissue and push it back on the socket, again deepening that socket, where the ball is the very upper portion of the screen to the right. So I'd like to really go back and jump ship a little bit more to the younger type of injuries that occur, which is more soft tissue, labrum stability. Again, the rotator cuff, unless it's more traumatic, it occurs a little bit in the older individual, and obviously as you mature and you get older, you can get more rotator cuff pathology. But the instability, the inherent labrum, biceps problems, is more in the younger individual, the athlete, so to speak.
Correct. So that's really the weak link in the chain when people are young, especially collision athletes. And there's two, you can look at instability a couple of ways. You have your overt instability like a shoulder dislocation. When a young person has a shoulder dislocation, almost 100% of the time they'll have a labral tear of the labrum, typically in the front. And then we have what we would call maybe micro instability, where it's not a traumatic event such as a shoulder dislocation, but maybe with the overhand athlete, collision athletes, they will have some micro instability, which can also lead to symptoms and pathology at any part of the labrum.
So generally when you have a dislocation, now there's obviously different types of dislocations, where the
Correct.
ball dislocates to the front, where the ball dislocates to the back, and also the ball can dislocate down,
Straight
which
down.
is pretty rare. But really more than 95% of the times, the ball dislocates to the front. That's sort of the weaker link. That's when your shoulder is more in this position, which
Correct.
is more common. When you play football and you block and your arm kind of goes out to the side, you can have a dislocation. That's a traumatic event. And even for young individuals, 15, 16, once they have that initial dislocation or anterior dislocation of the shoulder where the ball comes out to the front, even if the ball is put back on its own or somebody helps put it back, what's the risks of that individual having another dislocation where the ball is going to pop right out again?
It depends on the individual, but particularly in the collision athlete, that risk approaches 95% or more. So it's almost a guarantee. You have to look at the patients and particularly look at their other shoulder, because just like anything else, there are different degrees of inherent stability depending on the person. So certain people will inherently have looser shoulders, and they may or are more prone to dislocations, and it may be from a very minimal or maybe even no trauma, as opposed to a patient who has more typical stability, and that initial dislocation is almost always traumatic.
So you're really differentiating between the hyperlaxity type of individual and the more stable individual who had a really traumatic event but doesn't really have more laxity in his tissues.
Exactly, and it's all in the history again. You just have to listen to the patient. They'll usually tell you which one it is. And it's important to remember, because like we treat those patients differently. The hallmark of treatment for the patient who has a loose shoulder, who maybe didn't have a trauma or had a very minimal trauma, is to strengthen the dynamic stabilizers around the shoulder, and those are the muscles, as opposed to the patient who has instability in one direction from trauma. That's the person you need to keep a very close eye on. Some people will operate on an initial instability event in a high-risk patient, but pretty much everyone would agree that if that becomes recurrent, that is somebody that you should fix. So
generally when I see a patient, let's say I had a dislocation of the shoulder, and I want to assess if they have some laxity or they're sort of loosey-goosey or loose jointed.
Sure.
You know, also look at, let's say, the elbow, or if they can bring the thumb down to the forearm,
Sure.
or their knees, to assess if they're sort of lax overall. It's also those party tricks that, you know, you sometimes see individuals do, where they kind of pop out the shoulder and the arm goes above the head to the back, and all of a sudden it goes back. Those are voluntarily dislocating or subluxing the shoulder.
Right.
And you have to approach that individual very different from the guy who played football and dislocated his shoulder.
Very differently, very differently.
So what happened if you take that patient, that's sort of a loosey-goosey individual, and say, okay, you dislocated your shoulder, we're going to go and repair you surgically?
Right. So you need to keep that in mind. People, it's a fine line, because people who are hyperlax, they won't necessarily be happy with a very tight shoulder. But they just have to know going in that if the goal is to stabilize the shoulder, they may not have that motion that they used to have, because inherently you're going to be taking that away if the goal is to keep that shoulder from dislocating.
So you got to have to sort of make a switch or determination between stability and some stiffness or some loss of motion.
Right, and especially if that's the dominant arm of a thrower, they need to know that going in. The goal obviously is to get it just right, to give them stability with minimizing loss of motion.
So going back to the individual that had a traumatic dislocation, they're not sort of loosey-goosey or double jointed, as they say. When you go in, let's say it does get repaired, because the high risk of dislocating the shoulder again in a younger individual up to, let's say, mid-20s or so, is above 90-95%, which means it can happen again.
It's almost a guarantee to happen again, actually.
Especially if they're still obviously involved in sports.
Correct.
So that individual had the surgery, you gained that stability back. Again, it's important to assess if it's a dominant shoulder versus a non-dominant shoulder. And a lot of times, especially in throwers, the rotation that you get from the shoulder, let's say I'm right-handed, you're able in a pitcher to actually rotate that arm much further back than their non-dominant shoulder. So for a pitcher, they gain more external rotation, but they can lose some of the internal rotation. And their shoulders are actually very different. And if you tighten them up compared to a non-dominant arm, they can lose that speed and power when they pitch or throw.
Absolutely, they will develop less torque. And I think on the picture you showed before, that's not an exaggeration. If you watch some super slow-mo of throwers, their forearm, when they're in the late cocking phase, is almost parallel to the ground. Now, they will lose some internal rotation, so when you're evaluating a thrower, you have to know that. And we're looking maybe not how far they go externally and internally alone, but compare that as a combined arc of motion. And then you'll look at their other shoulder, because with a thrower, they may lose so much internal rotation that in and of itself can start to lead to problems.
And when you have that much sort of external rotation, you're able to pull your arm so far back, that can cause a little impingement of the rotator cuff to the back part of the shoulder, which
Correct.
you don't see in a, let's say, older individual.
It's called internal impingement, actually. It's a very specific category of pathology.
Unlike impingement, where you see impingement of the rotator cuff.
Correct.
Seeing more of that kind of a lot of people refer to as a bony spur that's pushing on the rotator cuff, which you see it really in an older individual.
Correct.
And now let's take that individual that had a dislocation of the shoulder in the operating room. What should they expect regarding their rehab as opposed to, as we spoke about, the rotator cuff rehabilitation?
Right, so unlike the rotator cuff, the labrum, the process of healing is much faster. So the typical time of immobilization is shorter, initiation of motion is shorter, and we would expect overall recovery to be faster. Now, there certainly is a risk of recurrent instability. When we are repairing the labrum, we are not doing something that is greater than nature. We're just trying to restore normal anatomy. So when you repair a labrum, it's not invincible. It is going to be subject to the same risk that it was subject to before you ever had a dislocation, which is a risk.
But the risk of dislocating once you have the repair should be lower than if you did not have a repair in a young individual.
Sure, yeah. I mean, the risk of instability in a younger individual, a West Point cadet, for example, is 97%. So certainly our surgery works better than 3%.
And now just jumping to the, let's say, older individual who dislocates their shoulder. that is a different pathology and finding than the younger individual who dislocates the shoulder and only has a labral tear, or that soft tissue tear.
Correct. So, we use the age cutoff of 40, not that something magically happens when you turn 40.
But 40 is still very young, just for the audience to know.
Very
young.
So, but we know that from studies that categorize patients by broad age groups, that over age 40, the weak link in the chain starts to become the rotator cuff. So when the shoulder dislocates, the failure is a rotator cuff tear as opposed to a labral tear, which they may also sustain.
So somebody, let's say 66 and dislocated the shoulder, they may have a labral tear, but they can also have a rotator cuff tear.
They probably do, actually.
And that's, again, the different surgery, the different rehab of what they can do. And they may actually notice that they all of a sudden have this weakness in the arm, because that's a traumatic tear.
They may actually have trouble lifting their arm up. They may have trouble brushing their teeth or brushing their hair.
And especially, again, above shoulder level type of activities. Let me talk a little bit the biceps.
Sure.
Now, the biceps, which is your guns, really have two tendons. That's why it's a biceps.
Correct.
And one of those tendons, it's a long tendon that goes all the way into the joint, as is shown in some of those pictures.
Right.
So it's an intra-articular tendon, which I know there's a lot of controversy. What do you do with that biceps tendon in different scenarios?
Sure.
So I don't want to put you on the spot, but definitely with your expertise, you've seen a lot of biceps tendons and a lot of different things that could be done with the biceps.
Yeah.
How do you approach this biceps tendon, or what we call also SLAP instability, if we know a little into SLAP?
Sure. So the SLAP stands for superior labrum, the top part of the labrum, anterior to posterior, front to back. And it can occur from either a single episode or multiple traumatic episodes where the biceps, where it attaches, the anchor peels off. And we really didn't recognize this until the advent of arthroscopy, because we never really saw it, because we couldn't put our eyes on it. It can absolutely be a pain generator, whether a problem of the biceps tendon itself in the shoulder, a problem in the groove that it is in before it gets into the joint, or at the anchor itself. And we need to be careful when we're treating them, because one thing that can happen is you fix the superior labrum in the wrong person, you can really constrain their shoulder. So I would say over the last several years, there's been a drive to performing what's called a biceps tenodesis, where instead of fixing it at the top of the labrum, you remove that attachment, you remove the deforming force, and you want to hook the biceps up somewhere else on the arm so that it has proper tension to minimize the likelihood that somebody gets weakness of using their elbow, which is usually very subtle weakness, or cramping of the biceps, which would be more common.
And really the biceps muscle, not, again, the guns, it not only does flexion, but actually does what we call supination, which is rotation of your hand this way.
Right.
So if you rupture your biceps tendon, which again, the long biceps tendon, that tendon that goes into the shoulder, is at a higher risk for rupturing than the shorter tendon.
Absolutely.
You actually will lose mobility or strength really on rotation. You'll feel weaker able to rotate, not just flex your arm, but also rotate.
Correct.
Which is why if you do cut it, let's say inside the shoulder, you fix it somewhere else.
Sure. When it's controlled, we always like to be able to control it. There are a lot of people who will have biceps tendon rupture spontaneously. It may happen just by itself because the tendon's beat up. It may happen more commonly and associated with a rotator cuff tear. But if there's a traumatic rupture of the biceps on its own, we usually don't go fix it right away, with the exception of somebody who doesn't like the appearance, like what we call a reverse Popeye. Somebody can bend their arm up, and because that outer head of the biceps is dropped down, they get a big peak on their biceps. Actually, some people like that.
So, so the individual actually may be able to, it happened maybe like a pop or something
Sure.
happened. Usually it's what we'll call an eccentric contraction. You're trying to lift something very heavy and it sort of kind of gives out on you and pulls your biceps down. And there's a pop, and you can get sort of this bleeding or black and blue that occurs at the skin. And all of a sudden you're going like this, and you notice that one arm, the muscle looks bigger, but it's shifted more towards the elbow. That gives a clinical indication off the bat for an orthopedic surgeon that you had a rupture of your biceps. But it doesn't necessarily mean that it's painful. You can still function with it, which is why you're saying, you can leave it, especially depending on the younger versus older individual,
Sure.
the type of job that you do, manual labor versus, let's say, office work. And there's different ways you can approach it in order to obviously fix it.
Right.
So if you do, let's say, fix it, the biceps, it's a pain generator, it's a problem within the shoulder. When do you figure you're going to do it arthroscopically versus open, making a sort of incision here and fixing it by an open technique?
So it all depends on where you think the problem might be. It can be done below the groove, which is a pain generator. It can be done in the groove for maybe a problem with the slap. It all comes down to how you feel comfortable doing it, A, and B, how you feel is a strong way to do it, healing being the key. And now we can do them either arthroscopically, with typically you're going to stick the tendon into the bone, something to fix it in there, an anchor, a screw, or you can make a small incision that you almost can't see right here under the fold of your arm, and you can do it through an incision about 2 inches smaller. And again, there's a variety of ways to get it to hook onto the bone, but what you're trying to do is keep that tension. So you end up losing a lot of tendon, because if you take the tendon from where it attaches up top and you hook it up somewhere below, there'll be so much slack in it that it's really not very functional.
So you do have to take part of the tendon away in order to maintain that sort of
Sure. I mean, you
tightness.
can see in the image right here, this is the biceps tendon. The muscle starts down here, and this tendon runs all the way up into the joint. So when you're going to fix it down here, you really only need that much tendon.
And again, that's a tendon here. This is the muscle which starts right here.
Correct.
So if you fix it further down here, you do have to remove a lot of the tendon that goes into the joint
Correct.
itself.
It's excess.
So we kind of touched a little bit about the instability, the biceps tendon, the labrum, slap, and really the younger versus older individual regarding instability and dislocation. We're going to take a short break, and we'll come back, and I really want to talk about both issues together, maybe some of the surgical intervention of how we do it, chances of healing, and what to expect. I'm Dr. Lahav. With us here we have Dr. Schachter, and we'll be right back to Healthcare from the Hill to talk about your shoulder. Stay tuned. Welcome back to Healthcare from the Hill. I'm Dr. Lahav, and we're discussing shoulder issues, rotator cuff, instability, labrum, and biceps with Dr. Schachter, specializing in sports medicine and arthroscopy. So in this last segment here, I want to really kind of go back a little bit into just the surgery part. If, let's say, a patient is indicated for surgery, they're going in, is it outpatient versus inpatient surgery? Sure. How long does it take? Really for both surgeries, and what are the ways you can repair it? You mentioned, suture and anchors. What does that mean?
Sure. So it's outpatient surgery. We do it arthroscopically for the most part, with some exceptions. We'll go into the rotator cuff first, so that surgery can take anywhere from the small tear from 40 to 45 minutes to these big monsters that can take 2 hours or more. The patient's going to go home, they're going to be in a sling. I tell everybody after shoulder surgery, if you ask 100 people, different kinds of shoulder surgery, what was the biggest drag about recovery? You're going to get about 99 people saying sleeping at night, just because it's very difficult to sleep in an immobilized position. A lot of time people will sleep in a recliner. They usually have to sleep in a semi-reclined position, so they're build it up with pillows. I never tell people they have to sleep in a recliner. People will start asking me, can I sleep in my bed? I say, I don't know, can you?
That's true. What about the repair itself? And I know there was, originally it was sort of a one-row repair versus a double-row repair, and there had been some changes actually to the techniques. Maybe you can just explain, let's say, 1 versus 2 row. What does that mean?
Sure. We'll go back. Historically, when it was done opened, we drilled tunnels through the bone. Sutures went through the bone, up through the tendon, and then you tie the tendon back down to itself. As arthroscopic techniques began to emerge, we needed a way to do it. And so the answer then was to put anchors. They're made of plastic or composite materials. The anchor goes in the bone. That is the fixation point for the suture. So the suture is going to go up from the anchor, which is in the bone, and bring the tendon back down. Over time, with the goal being to develop stronger repairs, instead of just doing 1 line of anchors, they developed techniques to do 2 lines of anchors or a double row repair, and that is in order to provide a broader area of compression, with the goal being increased healing rates. Some studies support that their healing rates are higher, others support that's not the case. It's a very debatable topic in the end. And even more recently now, there's been techniques to actually do what, kind of back to the future, devices that can now arthroscopically drill the tunnel in the bone and pass the suture through it, with the advantage of that being potentially a cost saving. We're all cost conscious these days, and anchors are not cheap. The material isn't cheap. And also with tunnels, if you have to go back, you won't run into any problems of what do we do here because there's this big anchor and now there's a big hole.
And let's just jump a little bit ahead for those, let's say, older individuals with a massive rotator cuff tear that's unrepairable. The tissue cannot be pulled back to the bone. The tissue is not strong enough even to hold any stitches or suture. What do you do with that individual that kind of lost that motion, but the rotator cuff is it's not repairable?
Right.
What options do they have?
So assuming they're going to do a surgical option, a lot of those patients can be treated well conservatively. If you have an irreparable rotator cuff tear, that means that it has been so far away from that its home for so long that it's under so much tension, or it may not even be able to reach that because the muscle will become atrophied and the atrophic muscle is not as flexible. So now you're looking at more salvage procedures. And over the last several years, there have been a significant increase in performing what's called a reverse shoulder replacement. So instead of doing a ball and socket, which if there's not a rotator cuff to hold the ball into the socket, that will fail, they switch it. So you put the ball on the socket side, the socket on the ball side. That provides a pivot point for your deltoid muscles to work against.
So you're really changing sort of the moment arm of the shoulder using your deltoid, which is the muscle you generally feel here.
Correct.
To really work instead of the rotator cuff. And it's sort of a newer type of surgery where, again, you do take the ball, put it on the socket, and take the socket and put it on the ball. You flip that around,
Right.
just to give you kind of that bigger moment arm, to give you, again, more functionality. So those patients would expect maybe to see a little bit better motion of the arm, correct?
Absolutely. Better motion with less pain, but they should also know going in that it is a reconstructive procedure. We're not talking about outpatient surgery here. We're talking about, a shoulder replacement, which is not a small surgery.
So that is an inpatient procedure, obviously a bigger deal.
Right.
And that includes a lot of metal there. With a different rehab than rotator cuff and things like that.
Much.
But you do start to work those patients earlier because essentially it's a joint reconstruction.
It's a joint reconstruction. And the reason that we are slow with repairs is because we want the tendon to heal. In the setting of reconstruction, we're talking about rotator cuff, it's not just for arthritis. The things that we're waiting to heal, they aren't there anymore. The reason why we're doing the surgery is because those things are gone.
And while we have just a couple of minutes left, I just want to touch on the conservative management.
Sure.
Not everybody needs surgery, so let's start with the younger individual with some instability or first dislocation. If they're not interested in surgery, what do you start conservatively?
Sure, we're going to have a very short period of immobilization, typically a couple of weeks. We'll begin early physical therapy for range of motion, with the exception of getting in that position of instability, which is kind of somewhere back here that we want to avoid. We want to let the soft tissues around the shoulder heal as much as they can, and then progress with strengthening. And return to sport, depending on the sport, can be anywhere from 8 weeks to 3 months. Collision athletes should know that they're at a higher risk for instability. There are a couple of shoulder braces that people can wear that can kind of try to keep them from that position, particularly if somebody who has a desire and a goal of trying to get back earlier.
So those individuals also will return kind of their own pace. But you're using sort of dynamic strengthening with the rotator cuff to compensate for the lack of labrum, to kind of keep that ball
Correct.
back in the socket.
As much as it can. We know it can't make up all of the difference, but it can certainly make a difference.
All right, so really doing the rehab is very important on a more persistent basis.
It's very important, and it doesn't work if you don't do it.
Exactly, dose dependent. And then going to the older individual for, let's say, a rotator cuff, it may be, moderate or even large cuff, and they're, so look, I really don't want surgery. I just want to know what I can do to make this better.
Right, so you're going to strengthen, you're going to take you're going to work with what you have. You're going to strengthen what's left, which are shoulder blade muscles. The shoulder blade moving on your skeleton actually provides about 1/3 of shoulder motion, and it's about 50% of shoulder motion when your arm's above shoulder level. So you're going to work on the things you have. You're going to strengthen your deltoids. You're going to strengthen the rotator cuff muscles that you think are there, and in the end, if the shoulder moves more properly, you can absolutely have an improvement of pain. But sometimes people do well, sometimes they don't. Sometimes people don't want surgery, but it's not maybe that they don't want surgery, it's they would prefer not to have the problem that requires surgery.
And in addition to the therapy or the exercise that you do, anti-inflammatory medications like Motrin, Advil, ibuprofen, some of the prescriptions over-the-counter ones, we also tend to use to decrease some inflammatory response to make it a little more comfortable.
Every little bit helps.
That's right. And then really beyond that, where do you see really injections to the shoulder, like a cortisone injection to the shoulder?
That can be very effective for acute, especially acute inflammatory problems like a frozen shoulder, like the rotator cuff tendonitis, or like biceps tendonitis. We like to stay away from injections in the setting of trauma, but for overuse or atraumatic problems, they're absolutely an option, and used in the proper setting can be very effective.
So would you go with an injection for a younger individual?
No. We want to be really careful about injections. It does good things, but it's not magic. There certainly are drawbacks, and that steroid material can transiently weaken some of these structures. So I would be very apprehensive to use it in somebody who's young.
So really a steroid, or what a lot of people consider like cortisone injections, and there's a lot of different steroids that we use. It's sort of like a double-edged sword. It's a very good anti-inflammatory, or like you put a Motrin in the shoulder.
Sure.
But at the same time, with too much steroid, actually weakens the tissues, weakens the tendons, and can lead to tears in the soft tissue.
Right, and that's probably the last thing you want to do is make a problem worse.
Except maybe for one issue where you have sort of a biceps tendonitis in a younger individual, more towards a groove, not up in the shoulder, more towards in the groove, where you can also use that as maybe a diagnostic tool to figure out if really the pain in the shoulder is coming from the biceps, not from within the joint.
Absolutely. Diagnostic injections are important because it's not like MRI shows every problem that there is and exclude everything that there's not. There are a lot of incidental findings. So when you're treating somebody, you want to make sure you're treating their symptoms, not their images. And so even an injection of only local anesthetic can be very effective as a diagnostic tool.
And for those injections given to the shoulder, let's say in an older individual, if they have what we'll call bursitis, or just no rotator cuff tear, even if you diagnose it on physical exam and or using an MRI, but they sort of have a little bit of, we call impingement or bursitis or rotator cuff tendonitis. Do you have any reservations about doing what we call a subacromial injection that goes above the rotator cuff?
Not much. I think our threshold is certainly a little lower for using it in that setting. It's not perfect. There can be some side effects. You need to be careful with people who have diabetes. They should know that their sugar may go up. But I think it is oftentimes a part of successful conservative management. It can kind of give them a window of opportunity to work through.
All right, so for those individuals, it can give them actually a great response, and the pain essentially goes away. They feel better. They're able to sort of return back to the things that they were doing before. And just one more on the injections is when you give actually injection into the joint, the glenohumeral joint between the ball and the socket, which is more for arthritis type of symptoms. That can also provide some relief because it's taking kind of that Motrin and putting it inside the joint, again, like you do also in the knee, to provide us some relief as well. So we really kind of talked about rotator cuff, instability, biceps, conservative versus surgical intervention regarding all these conditions. And really the individual issues that occur in the shoulder do depend on age and do depend on your athletic ability and what you do. So it always matters really how old you are, the history, the physical examination, really diagnosing what the problem is before you're proceeding with what you want to do with it. Being conservative, being surgical, seeing an orthopedic surgeon, especially one who has specializing or specialty really in shoulder, in sports medicine, arthroscopy, like Dr. Aaron Schachter. Really you want the gold standard. You want someone who's been doing it for a long time, seen a lot of athletes, and really can maybe make some of this really fine differentiation between what is the best thing for you as an individual. You could be young at heart, or you could be older or more mature. But you have to kind of take all these issues about the shoulder together, from the rotator cuff to instability, and make the right choice for you. This is Healthcare from the Hill. I'm Dr. Amit Lahav. Thank you for joining us today. Thank you, Dr. Schachter, for being with us. And we'll see you next time on Healthcare from the Hill. Have a good weekend. There's nothing back there that's gonna.
We are clear. Good show.